Hello and welcome back to the Oncology Brothers podcast. I'm Rahul Gosain. As always, I'm here with my brother and co-host Rohit Gosain. We're thrilled to bring you the latest from the ASCO 2025 annual meeting, where thousands of abstracts were presented. And today we're focusing on breast cancer, and we have narrowed it down to 5 important abstracts. To cover this, we're excited to have Dr. Erika Hamilton from Sarah Cannon Research Institute, who is also the Scientific Committee Chair for ASCO 2025 meeting. Erika, congratulations on an outstanding ASCO, and thank you for being here today.
Thanks. I'm happy to join you guys.
Wow. Erika, congratulations again. ASCO 2025 was a huge success as we saw quite a few practice-changing studies. Focusing on breast cancer arena here. Hormone receptor-positive space, we'll talk about INAVO120, SERENA-6, and VERITAC-2. And in HER2-positive space, we'll cover DESTINY-Breast09 and closing off with ASCENT-04 from triple-negative breast cancer. Before we kick off with INAVO120, I do want to reiterate updated data that we saw from SOFT and TEX trial with ovarian suppression with aromatase inhibitor in high-risk premenopausal women, which ends up being the treatment of choice given improved breast cancer-free interval and overall survival. Okay, now on to INAVO120. Inavolisib was approved back in October 2024 for patients with PIK3CA mutated disease that had recurrence on or after completing their adjuvant endocrine therapy within 12 months. So a very high-risk population. Erika, can you please start us off here with study and its findings?
Yeah, absolutely. So this was a pretty straightforward design, randomization 1-to-1 in the first line space. So different than we see with other PI3 or AKT, where we're really talking about post-CDK. So this was a fulvestrant palbociclib alone or fulvestrant palbociclib with inavolisib. And everyone had PI3 alterations. But what's really unique here is that they had to have progressed within 12 months or while on their adjuvant AI. And remember, when we look at these results, that the FDA pooled analysis for all three of the CDK4/6s showed that patients just with a PI3 alteration are not a set of patients that we actually worry about their benefit from CDK. So what's unique about this population is really that quick relapse from the adjuvant setting. Progression-free survival is more than doubled, almost tripled, 7.3 months with fulvestrant and CDK alone, 17.2 months with inavolisib. We should be getting around 20 months typically on a CDK4/6 inhibitor. Patients that relapsed early from adjuvant AI in the absence of a PI3, they're only having a PFS of 7 months. So this is really an exceedingly poor risk patient group. So definitely encouraging to see that 17 months that's more in line of what we would expect from first line treatment for patients with ER positive breast cancer. Also, overall survival, certainly our gold standard here. We saw 27 months without inavolisib, 34 months with. So essentially a 7-month benefit, and the p-value was 0.01.
So again, inavolisib is first in class to show overall survival benefit. But when we're talking about this class of drug, we have to keep hyperglycemia in mind. This is a class effect. And again, Rohit, you touched on this. Erika, you brought this up as well. This is high-risk patient, and we are seeing overall survival benefits. So this is meaningful, but we have to do better on our end to make sure we're getting through these side effects. Okay, sticking with metastatic hormone receptor-positive disease, our current standard of care here is CDK4/6 inhibitors with endocrine therapy. And then we start to look for some actionable mutations, particularly ESR1 mutation or AKT pathway mutations. But in SERENA-6, one of the plenary discussions, we were looking for a serial NGS for ESR1 mutation, a resistant mutation. And then there was a switch to camizestrant before there was an actual progression of disease on scans. Erika, can you touch on this strategy? And is this ready for prime time? Are we really changing the biology by hitting the disease early? Importantly, are patients living longer with this?
Yeah, I think you hit on exactly the questions we're asking ourselves. This was plenary. It's certainly a proof of principle for camizestrant. You brought up the big questions here, really around PFS2 and are people living longer? This is a paradigm shifting idea for breast oncology that we would use the emergence of a resistance marker like ESR1 in the absence of progression to potentially change therapy. These patients were on AI and CDK4/6 drawn every 2 to 3 months. If they popped positive positive for an ESR1 mutation. That's hinting to us that we're going to see progression soon. They did have scans. They didn't have progression at that time. They were randomized 1-to-1, either continuing their AI CDK or moving to camizestrant, the oral SERD with CDK.
And again, here we're looking at PFS and PFS2, but we have to be careful with this PFS2.
Absolutely. PFS, not surprisingly, definitely longer. 9.2 months with continuing your AI and CDK4/6. Another little thing that I gleaned from that is the average time, if somebody has a resistance mechanism and a new ctDNA finding like this, that it may take them to progress. And that's another 9 months. Camizestrant clearly doing much better here at 16 months. Progression-free survival, too, was trying to get at the question of, okay, well, that arm that switched therapy. So they'd kind of had two arms at that, two treatments at that point, and the other arm stayed on their one treatment. So it's not really comparing apples to apples. It's comparing a little bit 2 lines of therapy versus 1 line of therapy, albeit in the absence of progression. And so progression-free survival looked at that next line, and that was longer. At 12 months, 85.4% of patients on camizestrant CDK remaining progression-free, 74% on the AI and CDK. There was a great discussion by Dr. DeMichelle here at ASCO that it's not necessarily a completely fair analysis at this point. With that second line, we're almost comparing 3 lines of treatment to 2 lines of treatment. So I think a lot of us think that, yes, this probably is coming. Is it prime time ready today? No, I don't think so. I think ultimately, if we're going to do this for patients and, the cost and having to draw this every 2 to 3 months, I want to tell them that they're going to do better down the road based on this, that they're going to live longer, that we're going to be preventing some type of new metastases like a liver met, where they're going to be living better. And we don't quite have the data to do that yet.
Right, I totally agree. A great idea, especially making personalized treatment started earlier, but we do need longer term data before we all adapt this in our practice. Okay, while talking about ESR1 mutation space, now let's shift to VERITAC-2 trial. Erika, you led this trial for a PROTEC estrogen receptor degrader, comparing here to fulvestrant in ER-positive, HER2-negative advanced breast cancer. Erika, what did the data show, particularly for ESR1 population? If this gets approved, this will be in the same space as elacestrant. Where would you see this fit in your practice?
Yeah, so absolutely conflict of interest. I'm the one that presented this. This was a straightforward design. Everyone had to have had endocrine therapy with a CDK4/6 inhibitor, so very real world population. They could have had up to 1 additional line of endocrine therapy, and patients were not allowed to have prior fulvestrant since it was the control arm, or prior chemotherapy. We also wanted to make sure that these were patients that were reasonable to go on to further endocrine therapy, so they had to have benefit from their last line of endocrine therapy for at least 6 months. So comparing fulvestrant, which is intramuscular, twice in the first month and then monthly thereafter, versus vepdegestrant, which is a once-a-day oral medication. So if we move over to the data, essentially our primary endpoint was progression-free survival in those patients with ESR1 mutations. And if that was positive, then we would go on to test PFS in intention to treat all comers, regardless of mutations. And in fact, vepdegestrant did both statistically significantly and, in my opinion, clinically meaningful prolongation of progression-free survival, 5 months versus 2.1 months. I always like to look at the control arm. Is it what we would have expected? Absolutely. Fulvestrant 2.1 months is very in line with what we saw with the Emerald study of elacestrant, right at 1.9 months. Exactly what we would have expected. And remember that the Emerald study, everyone had seen a CDK. Now, if we want to compare it to imlunestrant, that's where it gets a little bit tricky because that was not apples to apples. About 30% of those patients with ESR1 mutations had not seen a CDK. That's why you see a little bit longer PFS in both arms, including the fulvestrant arm with imlunestrant. But I think we can compare this to elacestrant. When we looked at progression-free survival in all patients, no difference. So like we've seen with other drugs, the benefit was really among those patients that had ESR1 mutations.
Erika, can I push you a little more on this?
Sure.
If this becomes available, where would you use this? Who's the right patient?
I would use this second line for patients with ESR1 mutation. We all dread the cross-trial comparison. We all secretly somewhat do it as well. So if we look at the Emerald data, if it was 1.9 versus 3.8 months for patients that had ESR1 mutations, the fulvestrant arm is, comparing quite the same. And so perhaps vepdegestrant's a little bit better since we're getting 5 months. I certainly don't think it's worse. The other thing that stood out to me about this trial was the tolerability. For some of the drugs in the oral SERD class, gastrointestinal side effects can be a bigger deal for patients, nausea, vomiting, diarrhea. We saw very little of that with vepdegestrant. In fact, the most common side effect was fatigue, all grades, 27% of patients. So said another way, 3 out of 4 patients didn't complain of any fatigue. And then second and third side effects were LFTs and nausea. But both of those, again, any grade were in the low teens, less than 15%. What did not show up on our adverse event table was vomiting or diarrhea, because across any grade, that was only 6%. I really don't think that that's a signal that we need to worry about with this drug. So I'm happy with the activity and very happy with the tolerability.
ESR1 mutated space, we've seen this even with SERENA, is starting to get crowded. We're seeing these agents move earlier, and along with that, with combination. Okay, let's move on to HER2 positive space. Here, metastatic breast cancer, and we're looking at much awaited DESTINY-Breast09 trial. This looked into T-DXd with pertuzumab with standard of care taxane, trastuzumab, and pertuzumab.
This begins the section of your talk from the Jeffersons, moving on up. Every time I think about this or the ASCENT trial, I have that song playing in my head. You're right. The antibody drug conjugates have kind of taken breast cancer by storm, labor of moving these drugs up into the earlier and earlier line settings. DESTINY-Breast09 was first line HER2 positive breast cancer, comes after DB03, kind of making this the standard in the second line setting. Had a little bit of an interesting design because of our benefit with pertuzumab in this setting. So we had our kind of classic taxane with trastuzumab and pertuzumab, our gray arm. Then we had trastuzumab deruxtecan alone, but then also this bonus arm with trastuzumab deruxtecan plus pertuzumab. What we're presenting here is only the T-DXd plus pertuzumab arm. We don't have data from the T-DXd alone, so we can't answer the question right now of does pertuzumab add anything substantial to T-DXd. What we can say was that T-DXd plus pertuzumab easily beat chemo plus trastuzumab and pertuzumab. So progression-free survival was lengthened from right at about 27 months or a little over 2 years with taxane, trastuzumab, pertuzumab to almost 41 months. So the benefit, the delta here is about 13 months. So over a year improvement in patients remaining progression-free. Certainly, I think it's a little too early to see overall survival. This curve was shown. It was not significant at the time, but we know that our HER2 positive patients are doing well and have good long overall survival. So I'm not surprised that we didn't see that yet.
I'm going to sound like a broken record. Erika, what does it really mean for us today in our clinical practice? Are you going to use this just for induction? Are you going to use this only for high tumor burden, only for CNS disease? What are you going to do today?
And especially when it's just like lifelong chemotherapy type side effects.
Yeah, absolutely. I think you guys, per normal, hit on the very appropriate question. I think the data is really compelling. So yes, I am planning to use it first line. The bigger question is, am I planning to just continue it indefinitely 3 to 4 years? And no, I can't say that I am. The advantage, the thing we liked about the taxane, trastuzumab, pertuzumab is that we really treated for a number of cycles, 6 to 8 cycles, and then the chemo stopped. And they were just on antibody maintenance. And so that led to a good quality of life for our patients and, kind of not beating them over the head with chemotherapy for too long. I think that there's going to be a big desire for a maintenance strategy here. The question is, what is that maintenance strategy really going to look like? Now, remember that we also have patina data showing that a CDK4/6 inhibitor was very helpful in this space for patients that had ER positive. I think you're going to see a lot of people treating with trastuzumab deruxtecan for a certain amount of time, stopping that, and then moving to HP maintenance or HP endocrine therapy and a CDK per patina. the question we don't have the answer to is there a population that it's not appropriate to do that for? So for example, if somebody only gets stable disease and they're not maybe having a great response, that's probably not somebody that's going to do well on trastuzumab deruxtecan for a long time. So the type of trial that I'd love to see is, somebody that maybe had a very good partial response, 50 or 70%, stopping that patient after several months and maybe not stopping the patients that are showing us that they're not responding really briskly to trastuzumab deruxtecan. I think I would plan to do at least 6 to 8 cycles if I could. I think my strategy, again, completely absence of data, this is just my personal opinion, is that I'm probably going to treat to a maximal response. So as long as those scans are still showing shrinkage, I'm probably going to treat as long as people are tolerating it and can get more. And then once we stall at that maximal response, that's probably the time that I'm going to think about pulling it away. So if somebody's tolerating well and their cancer is still shrinking, I'd be willing to go to 10 cycles, et cetera. But I'm probably not going to give 3 or 4 years.
Indeed, patient-shared decision-making is going to be the key, especially when, again, the side effect profile is very similar to chemotherapy with ILD, alopecia, fatigue, nausea, and 2 deaths associated with this in this trial. Okay, now moving along into the triple negative space, where we have the data from ASCENT-04, where sacituzumab, yet another ADC, was tested with pembrolizumab in PD-L1 positive case, which is CPS more than or equal to 10 compared to chemo with pembro. Erika, your thoughts here?
Yeah, so the second of our moving on up. So straightforward design, chemotherapy, and you have your choice of paclitaxel, nab-paclitaxel, or the gemcitabine carboplatin combo with pembro versus sacituzumab govitecan. All of these have a little bit of a different schedule. Sacituzumab is the day 1 and day 8 every 21 days. And again, completely correct that this is for that subset of patients that are PD-L1 positive. And that tends to be about 35% of our triple negative patients in the first line, probably. So what we saw was a lengthening of progression-free survival, 7.8 months with chemo plus pembro and 11.2 months with sacituzumab govitecan and pembro. I think that this is really a very easy sell. Our patients with triple negative breast cancer are not doing as well as our HER2 patients or HR positive patients. This is not incredibly long. So I really can't think of a whole lot of reasons that I wouldn't want to offer my patient sacituzumab govitecan with pembro here. Obviously, we don't see any overall survival yet, but I'll also maybe throw a teaser out there that we have seen a press release that the companion trial to this, ASCENT-03, was also positive. And so that was the trial for the PD-L1 negative patients. So straight up chemo versus sacituzumab govitecan in first line triple negative. So we anticipate to see results of that at ESMO. So I suspect we don't have FDA approval yet, but I suspect we're going to see some of these changes over the next year in guidelines, et cetera. Most of our first line triple negative patients are going to be receiving ADC.
And again, the reason why you're saying it's an easy sell, because triple negative is such an unforgiving disease. So we want to make sure we're attacking this upfront aggressively.
Absolutely.
Erika, touching on some side effects that we have to worry about. Diarrhea, neutropenia. Now with pembrolizumab in itself can cause diarrhea, so there's some overlap side effects here. How are you going to decipher which one's which? And then can you also touch on growth factors here?
Yeah, I think very pertinent questions. Interestingly enough, when we looked at the adverse events, sacituzumab actually compared quite favorably to chemo. So, chemo certainly can cause neuropathy. It certainly can also cause neutropenia. So neutropenia really with both. The challenge with sacituzumab really is that day 1, day 8 administration, and you have a couple choices. I think pretty much universally, I'm giving a long-acting growth factor after that day 8 to try to boost the counts up high enough that we can kind of ride them through for the next cycle, because you can't give, a pegfilgrastim after day 1 because you're coming in with chemo on day 8. That works for some patients. For patients that it doesn't, I try to give short-acting Neupogen for. It's very funny what you can get approved. I remember we used to be able to send people home with syringes all the time, and then we got into this period where I had a lot of trouble having insurance cover that. Now we're back into a time where I've been very successful over the past year getting that for patients to have administration at home, which is much more convenient. So I do that. And then if we can't get the growth factor or we're having problems, I think about a dose reduction or an alter in schedule where you could actually think about giving day 1, day 15 instead of day 1, day 8. Has not been studied, but people are doing that sometimes when they're forced to. I think also diarrhea, great point. We definitely see that with sacituzumab govitecan. I find the diarrhea very binary. People either have it and they really have it, or they don't have it at all. I'm always amazed by the patients coming in saying, oh, I don't have diarrhea at all, right? So very different than TKIs where people are kind of universally going to get diarrhea. It's just a question of how bad. I think in terms of kind of how am I going to tease out if it's Pembro, the diarrhea from sacituzumab is going to start from the beginning. So it would really be a change in the characteristic of that diarrhea that would probably alert me to thinking about Pembro or immunotherapy-related diarrhea.
Absolutely. And again, there's a theme here. I said this with inavolisib, same story with sacituzumab. We're going to use these drugs. We have to get comfortable in managing these side effects and make sure our patients are safe on these drugs. Erika, we've covered a lot in a short time. Thank you so much for walking us through these key studies. And again, congratulations for an amazing ASCO 2025. For our listeners, let's go over a quick recap. In this episode with Dr. Erika Hamilton, we've covered 5 key abstracts in breast cancer from ASCO 2025. First, INAVO120, which showed promising overall survival data with inavolisib plus palbociclib and fulvestrant in PIK3CA mutated hormone receptor-positive, HER2-negative advanced breast cancer of 34 months versus 27 months. SERENA-6, a plenary highlight, demonstrated improved progression-free survival with camizestrant and CDK4/6 inhibitors in emerging ESR1 mutated disease versus waiting for disease to progress. Here, we need more mature data before we widely adapt this strategy for all our patients.
Then VERITAC-2 highlighted a vepdegestrant superior PFS over fulvestrant in ER-positive, HER2-negative breast cancer, especially in ESR1 mutated patients. This is a new class of drug that seemed to be very well tolerated. If approved, this will be in the same space as elacestrant. Then in DESTINY-Breast09, we discussed T-DXd plus pertuzumab significantly improving PFS in frontline HER2-positive metastatic breast cancer, challenging the Cleopatra regimen. Finally, ASCENT-04, sacituzumab with pembrolizumab in PD-L1 positive showed improved PFS benefit with sacituzumab govitecan. Thanks for joining us. Make sure to check out our other discussions, including treatment algorithms, recent approvals, and conference highlights. We are the Oncology Brothers.